And welcome to the video lecture for Unit 4, Module 9.4. And this one we're going to talk about age and fluid electrolyte and acid-base balance, as well as acid-base balance disturbances. As always, here are your learning objectives. Be sure to reference these when studying for both your lecture quiz as well as the unit exam. Let's go ahead and get started. So this image summarizes the interactions among the buffer systems, respiration, and renal function, and maintain normal to acid-base balance. In combination, these mechanisms can generally control pH very precisely, so the pH of the ECF seldom varies more than 0.1 pH unit from 7.35 to 7.45. When buffering mechanisms are severely stressed, however, the pH drifts outside of these limits, producing signs and symptoms of alkalosis or acidosis. If anyone considering a career in health-related field, an understanding of acid-base dynamics is essential for clinical diagnosis and patient management under a variety of conditions. Temporary shifts in the pH of body fluids occur frequently. Rapid and complete recovery involves a combination of buffer system activity and the respiratory and renal response. More serious and prolonged disturbances of acid-base balance can result under the following circumstances. Several conditions, including emphysema and renal failure, are associated with dangerous changes in pH. Conditions such as heart failure or hypertension can affect the pH of interstitial fluids by causing fluid shifts and changing glomerular filtration rates and respiratory efficiency. Neural damage or disease that affects the CNS can affect the respiratory and cardiovascular reflexes that are essential to normal pH regulation. Serious abnormalities in acid-base balance generally have an initial acute phase in which the pH moves rapidly out of the normal range. If the condition persists, physiological adjustments take place. The person then enters a compensated phase. Unless the underlying problem is corrected, compensation cannot be completed, and blood chemistry will remain abnormal. The pH typically remains outside normal limits even after compensation has occurred. Even if the pH is within the normal range, the PCO2 or the H3CO2 concentrations can be abnormal. The name given to the resulting condition usually indicates the primary source of the problem. Respiratory acid-base disorders result from a mismatch between carbon dioxide generations in peripheral tissues and carbon dioxide excretion by the lungs. When a respiratory acid-base disorder is present, the carbon dioxide level of the ECF is abnormal. Metabolic acid-base disorders are caused by the generation of organic acids or fixed acids or by conditions affecting the concentration of the HC3O2 in the ECF. Respiratory compensation alone may restore normal acid-base balance in persons with respiratory acid-base disorders. In contrast, compensation mechanisms for metabolic acid-base disorders may be able to stabilize pH, but other aspects of acid-base balance, such as buffer system function, bicarbonate, and PCO2 levels, remain abnormal until the underlying metabolic cause is corrected. We subdivide the respiratory and metabolic categories into four major classes of acid-base disturbances. 1. Respiratory acidosis, 2. Respiratory alkalosis, 3. Metabolic acidosis, and 4. Metabolic alkalosis. Respiratory acidosis develops when the respiratory system cannot eliminate all of the carbon dioxide generated by peripheral tissues. The primary sign is low blood pH due to hypercapnia and increased blood PCO2. The usual cause is hypoventilation, an abnormal low respiratory rate. When the PCO2 in the ECF rises, hydrogen and HCO3 concentrations also begin rising as H2CO3 forms and dissociates. Other buffer systems can tie up some of the hydrogen, but once the combined buffering capacity has been exceeded, the pH begins to fall rapidly. Respiratory acidosis is the most common challenge to acid-base equilibrium. Body tissues generate carbon dioxide rapidly. Even a few minutes of hypoventilation can cause acidosis, reducing the pH of the ECF to as low as 7. Under normal circumstances, the chemoreceptors that monitor the PCO2 of the blood and the cerebrospinal fluid eliminate the problem by stimulating an increase in breathing rate. If the chemoreceptors do not respond, if the breathing rate cannot be increased, or if the circulatory supply to the lungs is inadequate, pH will continue to decrease. If the decline is severe, acute respiratory acidosis develops. Acute respiratory acidosis is an immediate, life-threatening condition. It is especially dangerous in people whose tissues are generating large amounts of carbon dioxide, or in people who are incapable of normal respiratory activity. For this reason, the reverse of acute respiratory acidosis is probably the major goal in resuscitation of cardiac arrest or drowning victims. Thus, first aid, CPR, and life-saving courses always stress the ABCs of emergency care: airway, breathing, and circulation. Chronic respiratory acidosis develops when a normal respiratory function has been compromised, but the compensatory mechanisms have not failed completely. For example, normal respiratory compensation may not occur in response to chemoreceptor stimulation in persons with CNS injury and those whose respiratory centers have been desensitized by drugs such as alcohol or barbiturates. As a result, these people are prone to developing acidosis due to chronic hypoventilation. Even when respiratory centers are intact and functional, damage to some parts of the respiratory system can prevent increased pulmonary exchange. Examples of conditions fostering chronic respiratory acidosis include emphysema, congestive heart failure, and pneumonia, which typically cause alveolar damage or blockage. Pneumothorax and respiratory muscle paralysis have similar effects because they, too, limit adequate breathing rate. When a normal pulmonary response does not take place, the kidneys respond by increasing the rate of hydrogen secretion into tubular fluid. This response slows the rate of pH change. However, renal mechanisms alone cannot return the pH to normal until the underlying respiratory or circulatory problems are corrected. The primary problem in respiratory acidosis is the rate of pulmonary exchange is inadequate to keep the arterial PCO2 within normal limits. Breathing efficiency can typically be improved temporarily by inducing bronchodilation or by using mechanical aids that provide air under positive pressure. If breathing has stopped, artificial respiration or a mechanical ventilator is required. These measures may restore normal pH if the respiratory acidosis was not severe or prolonged. Treatment of acute respiratory acidosis is complicated by the fact that, as we'll soon see, it causes a complementary metabolic acidosis as oxygen-starved tissues generate lactic acid. Problems resulting from respiratory alkalosis are fairly uncommon. Respiratory alkalosis develops when a respiratory activity lowers blood PCO2 to below normal levels, a condition called hypocapnia. A temporary hypocapnia can be produced by hyperventilation when increased respiratory activity leads to a reduction in the arterial PCO2. Continued hyperventilation can increase the pH levels as high as 8. This condition generally corrects itself because the reduction in PCO2 halts the stimulation of the chemoreceptors, so the urge to breathe fades until carbon dioxide levels have returned to normal. Respiratory alkalosis caused by hyperventilation seldom lasts long enough to cause a clinical emergency. Common causes of hyperventilation include physical stresses such as pain or physiological stresses such as extreme anxiety. Hyperventilation gradually increases the pH of the cerebrospinal fluid, and the central nervous system function is affected. The initial symptoms involve tingling sensations in the hands, feet, lips. If the person may also feel lightheaded. If hyperventilation continues, the person may lose consciousness. Unconsciousness removes any contributing physiological stimuli, and the breathing rate decreases. The PCO2 then increases until pH returns to normal. A simple treatment for respiratory alkalosis caused by hyperventilation is to have the person breathe air exhaled into a small paper bag. As the PCO2 in the bag increases, so do the person's alveolar and arterial CO2 concentrations. This change eliminates the problem and restores the pH levels to normal. Other problems with respiratory alkalosis are rare and involve primarily 1. Persons adapting to high altitudes, where the low PO2 promotes hyperventilation. 2. Patients on mechanical respirators. Or 3. Persons whose brainstem injuries rendered them incapable of responding to shifts in plasma carbon dioxide concentrations. Metabolic acidosis is the second common type of acid-base imbalance. It has 3 major causes. 1. The most widespread cause of metabolic acidosis is the production of a large number of fixed acid or organic acids. The hydrogen ions released by these acids overload the carbonic acid bicarbonate buffer system, so pH begins to decrease. We considered 2 examples of metabolic acidosis earlier. Lactic acidosis can develop after strenuous exercise or prolonged tissue hypoxia, as active cells rely on anaerobic respiration. Ketoacidosis results from the generation of large quantities of ketone bodies during the post-absorptive stage of the metabolism. Ketoacidosis is a problem in starvation and potentially lethal complications of poorly controlled diabetes mellitus. In other cases, peripheral tissues cannot obtain adequate glucose from the bloodstream, and they begin metabolizing lipids and ketone bodies. 2. A less common cause of metabolic acidosis is an impaired ability to excrete hydrogen by the kidneys. For example, conditions marked by severe kidney damage, such as glomerulonephritis, typically result in the severe metabolic acidosis. Diuretics that turn off the sodium-hydrogen transport system in the kidney tubules also cause metabolic acidosis. The secretion of hydrogen is linked to the reabsorption of sodium. When sodium reabsorption stops, so does the hydrogen secretion. 3. Metabolic acidosis occurs after severe bicarbonate loss. The carbonic acid bicarbonate buffer system relies on bicarbonate ions to balance hydrogen ions that threaten pH balance. A decrease in the HCO3 concentrations of the ECF make this buffer system less effective, and acidosis soon develops. The most common cause of HCO3 depletion is chronic diarrhea. Under normal conditions, most of the bicarbonate ions secreted into the digestive tract and the pancreatic, hepatic, and mucus secretions are reabsorbed before the feces are eliminated. In diarrhea, these bicarbonates are lost, so the HCO3 concentration of the ECF decreases. The nature of this problem must be understood before treatment can begin. Potential causes are so varied that clinicians must piece together relevant clues to make a diagnosis. In some cases, the diagnosis is straightforward. For example, a patient with metabolic acidosis after a bicycle race probably has lactic acidosis. In other cases, clinicians must be detectives. Compensation for metabolic acidosis generally involves a combination of respiratory and renal mechanisms. Hydrogen ions interacting with bicarbonate ions form carbon dioxide molecules that are eliminated by the lungs. The kidneys excrete additional hydrogen ions into the urine and generate bicarbonate ions that are released into the ECF. Respiratory acidosis and metabolic acidosis are typically linked because oxygen-starved tissues generate large quantities of lactic acid and because sustained hypoventilation leads to decreased arterial PO2. The problem can be especially serious in cases of near drowning, in which body fluids have high PCO2, low PO2, and large amounts of lactate generated by the muscles of the struggling person. Lactate ions and hydrogen ions are released by the dissociation of lactic acid. Prompt emergency treatment is essential. The usual procedure involves some form of artificial or mechanical respiratory assistance, coupled with intravenous infusion of isotonic solution that contains sodium lactate, sodium gluconate, or sodium bicarbonate. Metabolic alkalosis occurs when HCO3 concentrations are elevated. The bicarbonate ions then interact with hydrogen ions in solution, forming H2CO3. The resulting decrease in hydrogen concentration causes signs of alkalosis. Metabolic alkalosis is rare, but we noted one interesting cause earlier. The phenomenon known as the alkaline tide is due to the influx into the ECF of large numbers of bicarbonate ions associated with the secretion of hydrochloric acid by the gastric mucosa. The alkaline tide temporarily increases the HCO3 concentrations in the ECF during meals. But bouts of repeated vomiting may bring on serious metabolic alkalosis because the stomach continues to generate stomach acids to replace those that are lost. As a result, the HC3O2 concentrations of the ECF continues to increase. Compensation for metabolic alkalosis involves a decrease in breathing rate coupled with an increased loss of HCO3 in urine. Treatment of mild cases typically addresses the primary cause, generally by controlling the vomiting, and may involve administering solutions that contain sodium chloride or potassium chloride. Treatment of acute cases of metabolic alkalosis may involve administering ammonium chloride. Metabolism of the ammonium ion in the liver liberates a hydrogen ion, so that in effect, introducing of ammonium chloride leads to internal generation of HCl, a strong acid. As the HCl diffuses into the bloodstream, pH falls towards normal levels. Additional steps can help in identifying possible causes of the problem and in distinguishing compensated from uncompensated conditions. These steps may include determining the anion gap, plotting the blood test results on a numerical graph called a nomogram, or using a diagnostic chart. Fetuses and infants have a very different requirement for maintaining fluid, electrolyte, and acid-base balance than do adults. A fetus obtains the water, organic nutrients, and electrolytes it needs from the maternal bloodstream. Buffers in the fetal bloodstream provide short-term pH control, and maternal kidneys eliminate the hydrogen generated. A newborn's body water content is high. At birth, water makes up about 75% of body weight, compared with about 50 to 60% in adults. Basic aspects of electrolyte balance are the same in newborns as in adults, but the effects of fluctuations in the diet are much more immediate in newborns because the reserves of minerals and energy sources are much smaller. The descriptions of fluid, electrolyte, and acid-base balance in this module were based on the responses of normal, healthy adults under the age of 40. Aging affects many aspects of fluid, electrolyte, and acid-base balance, including the following. Total body water content gradually decreases with age. Between ages 40 and 60, average total body water content declines slightly to 55% for males and 47% for females. After age 60, the values decline further to about 50% for males and 45% for females. Each decrease reduces the dilution of waste, toxins, and other drugs that have been administered. A decrease in the glomerular filtration rate and in the number of functional nephrons reduces the body's ability to regulate pH through renal compensation. The body's ability to concentrate urine declines, so more water is lost in urine. In addition, the rate of insensible perspiration increases as the skin becomes thinner and more delicate. Maintaining fluid balance therefore requires a higher daily water intake. A reduction in ADH and aldosterone sensitivity makes older people less able than younger people to conserve body water when losses exceed gains. Many people over the age of 60 experience a net loss in body mineral content as muscle mass and skeletal mass decrease. This loss can be prevented, at least in part, by a combination of exercise and increased dietary mineral supply. The reduction in vital capacity that accompanies aging reduces the body's ability to perform respiratory compensation, increasing the risk of respiratory acidosis. This problem can be compounded by arthritis, which can reduce vital capacity by limiting rib movements, and by emphysema, other conditions that, to some degree, affect with aging. Disorders affecting major systems become more common with increased age. Most, if not all, of these disorders have some effect on fluid, electrolyte, and or acid-base balance.